I'd also like to thank our institutional sponsors. I won't read them, all of them, but they play a hugely important role in the section on public health and preventive medicine. So with that, I'd like to turn over to the moderator for this evening, who is Dr. Cheryl Bedigol. Dr. Bedigol is the Division Director for Chronic Disease and Injury Prevention of the Philadelphia Department of Public Health.
Good evening, and thank you all for being here to talk about this important topic, and I am shorter than Michael. So I'm going to just walk you through a little bit of epidemiology of hypertension here in Philadelphia, and then introduce tonight's speakers. So just as background, we know that hypertension increases the risk of heart disease, congestive heart failure, of kidney disease, and of stroke. That nationally, 1 out of 3 adults have hypertension, and the rates are higher among those living in poverty. We know that there are behavioral risk factors mediated by socioeconomic factors that include high sodium diets, diets low in fruits and vegetables, low levels of physical activity, smoking, and excessive alcohol consumption. So this is a map of what hypertension rates look like in our city. And we've divided this into city council districts and council districts that are below the national average, which was 33.5% in 2016 when this data is from, and those that are above the national average. And as you'll see, pretty much all of Philadelphia is above the national average. And I'm not sure if you can read the numbers from where you're sitting, but many of our districts, many neighborhoods in the city have hypertension rates above 40%, so considerably higher than the national average. And it kind of doesn't matter where you live. So when we ask people if they have high blood pressure or hypertension, overall those rates are staying about the same, but it looks like we may be seeing some elevations in rates for non-Hispanic blacks in the city. And this data is from 2011 through 2017. We know that rates of hypertension are highest among non-Hispanic black women and non-Hispanic black men, so they're the highest bar in each of those graphs. And those rates, again, are well above 40%. When we look at hospitalizations for hypertension in Philadelphia, we see not only that rates are considerably higher for blacks than whites, but that the rates for blacks in our city start going up very, very early in life, as early as the 20s. And you see rates that are 2 to 3 times as high. And the same is true of death rates from hypertension and hypertension-related disease. Death rates for black Philadelphians being 2 to 3 times as high as those for whites, and those elevations starting as early as the 20s and 30s. So really, really early in life to see what we think of as a disease of older people. So I'm glad you're all here tonight. We all have a role in helping to prevent and to treat hypertension in our city. Yesterday, the City Health Department released a chart, a data brief on hypertension, and I hope you all got a copy as you came in. It's in blue, it's sitting on the table outside the door. If you didn't get a copy, please pick one up before you go. It has in it a little bit about what the city is doing, but also what healthcare providers and what individual people in the city can do to help prevent and to control hypertension, and we hope you will be partnering with us in this work. So it's now my very great pleasure to introduce tonight's speakers. So first up will be Dr. Jesse Goldman, who I met maybe, 10 years ago, in his role as a member of the American Society of Hypertension Delaware Valley branch. Dr. Goldman is a professor at Drexel University School of Medicine, professor of medicine, and he's the director of the American Heart Association accredited Drexel Comprehensive Hypertension Center. He's chair of the Drexel Biomedical Institutional Review Board and the clinical investigator on multiple clinical and epidemiological trials. He's been a great resource for me for many years on hypertension, and we're really lucky to have him with us tonight. Next up will be Dr. Jorde Cohen, who is an assistant professor of medicine and epidemiology at the University of Pennsylvania, also a member of the American Society of Hypertension's Delaware Valley branch, and whose clinical interests are complex hypertension management as well as disparities in care and development of hypertension. She is also the PI and co-PI on multiple studies, and serves as head of the education committee of the ASH Delaware Valley branch. And finally, Dr. Hannah Lahman, who I'm lucky enough to work with at the health department, will be wrapping up and talking about policy. And Dr. Lahman is our director of research and evaluation. She has a background in obesity, did her postdoc at Temple, and then went to work for N. Haynes, where she worked on obesity-related research. She also worked on Ebola in Africa, so has done a number of really interesting things, and will be talking with us tonight about the city's policy approaches. So, Dr. Goldman.
Turn the microphone on. Good. I'm glad someone's phone went off. It was a reminder for me to turn off my own phone before the telemarketers start again. So I want to thank Dr. Bedegal and Dr. Halpern and the American College for inviting me to talk about my favorite topic, thing that I think is most important, namely hypertension. I'll be speaking specifically about the 2017 ACC American Heart Hypertension Guidelines. The guidelines had, I should mention that I did not make a disclaimer or disclosure slide, but as mentioned, I am a PI on multiple clinical trials, none of which will be discussed today. I left my email here if people have questions or want a copy of any slides or just to flame me for saying something inflammatory. So the hypertension guidelines were very complex. Many investigators around, cardiologists, nephrologists, many physicians involved in their creation. Ultimately, a total of 11 hypertension or 11 medical societies signed on. They follow the Agency for Healthcare Research and Quality guidelines for guideline creation. I want to stress that guidelines are just that. They're not a mandate of what must be followed, but it's an analysis of, maybe all of you, maybe I'm bringing coals to Newcastle, but it's this idea that it's a suggestion to change therapy so that we're practicing optimal medically. It's not a mandate. Nobody's going to get sued for not following them. Within AHRQ, they grade both the strength and the level of evidence, and this has been followed in multiple other guidelines. A note, especially here at ACP, there were several societies that did not sign on. The European Society of Cardiology created their own guidelines, as did ACP and AAFP, and we'll talk later about some of the differences among those different ones. So, starting with observational studies, you don't have to look very far to find that on the left, from Framingham data, as well as from Mr. Fitt's study, looking at more than almost 13 million patient years, that those, I'm not sure, let's see, right, I'm not sure if this arrow comes through, no. Let me try this pointer. Oops, I didn't mean to do that. Okay. So you don't have to look very hard to see that lower, at least in epidemiologic studies, that lower levels of blood pressure have been described as being associated with lower cardiovascular event rates. Additionally, in the Cardia study, looking at 5,000 young adults, that this is an observational study also begun in 1985. In this recent publication, the investigators parsed it by the current 2017 AHA guidelines, which I'll be showing you shortly. And yes, there is an increasing hazard ratio, even at these relatively lower levels of elevated blood pressure, namely at the 120. So these are all adults who developed hypertension before age 40, and yes, the modest blood pressure elevations, even in the 120 range, that this observationally was associated with increased CV risk rates. You'd have to be hiding under a rock to not know about the SPRINT trial. This is not observational. This is quite large prospective randomized clinical trial of in excess of 9,300 non-diabetic hypertensives who were randomized to a systolic blood pressure below 120 or below 140. The study used ambulatory office blood, or excuse me, automated office blood pressure, something that's not readily available, but this 120 is thought to be perhaps equivalent to close to a 130 systolic pressure. I think many of you may know that the study was prematurely terminated because the subjects were randomized to a blood pressure less than 120, so that did much better, so that standard treatment was inferior treatment, right? So these people who were randomized to it, they had more cardiovascular death rates, more stroke, more heart failure event rates, and the study was terminated as a result. On 6 pre-specified subgroups, I'm not going to go into each of them, but you can see that the majority of the hazard ratios all fall to the left of 1, whether or not we're talking about these people had mild CKD or no CKD at all. They enrolled lots of older people. Everyone had at least one cardiovascular risk factor, African Americans, all different levels. They had to be hypertensive at the start. So this study also can be praised because they made an effort to examine frailty. And one of the complaints has been that we don't want to target lower blood pressures because my patients are too frail. In SPRINT, they evaluated frailty among older individuals as defined by speed of a 4-minute walk as well as a 37-minute survey. And on the left is the most fit, in the middle less fit, and on the right is most frail, people who really could not even walk. And as you might expect, the hazard ratios increase with sicker patients, more cardiovascular rates. But over and above that, the most frail individuals did benefit from achieving a lower systolic blood pressure below 120. I will remind you of the disclaimer that patients who had pre-existing orthostatic hypotension were excluded from participating. An extension study of SPRINT was to look at SPRINT Mind, namely the effect upon dementia and mild cognitive impairment. It's really quite hot off the press, and Dr. Welton, the lead author, discussed this with us at our own grand rounds, but there is a statistically significant difference of less mild cognitive impairment. The study was terminated again after only about 3.5 years, so they did not see a statistically significant difference in outright dementia, but there was a tendency towards separation of curves the longer we went. I don't show it to you here, but there is an MRI study that shows that even people with systolics in the 130, 140 range had more infarcts on MRI as compared to those with systolics of 120. A lot has been said about adverse events, and yes, there was a bit more hypokalemia and syncope, but there was no progressive CKD. In fact, we presented at the American Heart Association meeting that although there was some slight increase in AKI risk, this was not permanent, that it was all reversible. So yes, there was a bit more syncope, a bit more hypokalemia, probably attributable to increased use of diuretics to achieve that lower blood pressure rates. So this is the headline. People don't drill down on the 200 recommendations or so for American Heart. People want to, what really hits the newspaper and people's radar is these lower targets, initially somewhat shocking, right? That elevated blood pressure is defined as a systolic of 120 to 129. There's a disclaimer in it's devil's in the details. It's on 2 well-done, careful measurements on at least 2 different visits. I want to just mention that some of the still important but lesser recommendations of the guidelines. And this is really the biggest thing that's been lost, is that it should be filtered through the atherosclerotic cardiovascular risk rates, especially in people with ASCVD greater than 10%. The thought is that these people should have systolic blood pressures of less than 130. The goal blood pressure is to be less than 130, especially if your cardiovascular risk ASCVD score is higher, and also in older individuals over age 65. I won't read you the fine print, but all these guidelines have the disclaimers that yes, all of this should be done with careful interaction with patients, discussing possible risks and benefits. Why the ASCVD risk score? Well, Dr. Munter and Dr. Welton said that your blood pressure doesn't define your risk. So in the left panel, you can have, this is systolic pressure of 110 versus 130, and your ASCVD risk is a better predictor than your absolute blood pressure. That blood pressure is really just one of the cardiovascular risk factors. From Blood Pressure Trialist Collaborative Group, they looked at the systolic blood pressure reduction, 5-year risk rate, and cardiovascular preventing adverse events avoided. So for any given systolic blood pressure reduction, or for any given cardiovascular risk, a greater blood pressure reduction is associated with avoided cardiovascular risk. So if your patient is young and lean and has no has a very low ASCVD risk, their blood pressure probably doesn't need to be 125 because they're overall, but if there are additional ASCVD risk factors, these are the people who you really should consider treating lower. Well, I talked a bit earlier about the SPRINT trial. In SPRINT, the median ASCVD was 16. No surprise, the people who had atherosclerotic event rates had higher scores, and the curve begins to take off, increase that is, once your score gets above 10%. So the upper shaded panel is cumulative event rates by ASCVD. The American Heart Guidelines are similar to those of other global guidelines. So whether or not we're talking about the Canadian, Australian, the American Diabetes Association, or European Society of Cardiology, the American Heart Guidelines are all targeting lower systolic blood pressures after an analysis of the data. This leads to an automatic reclassification of millions of people. So in the United States, as soon as these guidelines came out, 31 million more patients, or 13.5% of people, got classified as hypertensive who didn't think that they were hypertensive the day before. This may be too small to read, but drilling down on some of the subgroups, every group, whether or not it's men, women, race, age, everyone had a higher rate of prevalence of hypertension. So as Dr. Bedigol mentioned, looking at these African American men and Hispanics, the people who need higher, who have increased cardiovascular event rate, you want those people to be identified as hypertensive because of their increased risk. The problem are some of these other perceived low-risk groups. So if you're looking, you're also reclassifying young women and very old people who've made it to the age of more than 75, not thinking that they were hypertensive. And these may be individual battles, maybe we can discuss in the question and answer period. So because there's people come in all different flavors, it's not one size fits all. For the sake of time, I'm not going to be able to go through this, just to mention that the American Heart Guidelines are quite similar to the European Society of Cardiology guidelines, and they differ. Same way to diagnose hypertension, statements that office blood pressure is better, that drug treatment should be done with ACEs, ARBs, and diuretics, Beta blockers should only be used in compelling indications. If your patient's blood pressure is quite high, start with 2 drugs. The guideline development processes were all the same. There were some nuance differences in that every guideline has some nuance differences. Just comparing these particular ones, the European guidelines, they stick to a grade 1, 2, and 3. They recommend predominantly push lifestyle modification much harder than the American guidelines do. And they do recommend not getting down below 120. The fear of risk was greater. So this is here, hopefully nobody will throw tomatoes here at ACP, but this is really the guideline that is in greatest contradistinction to the American heart guidelines. Namely, that the ACP and AAFP recommend initiating systolic blood pressure in age 60 and older only above 150. There is the disclaimer below that it should be after a discussion with the patient, but the headline is that 120s is not 150s. Lots of surus over this. Why might this be? I'm certainly not speaking for ACP. In drilling down on the ACP guidelines and what they reviewed, they looked at a lot of these older trials that compared 160s with 150s. And to be fair, similar to JNC 8, they attempted to only make recommendations that are based on evidence. Some more fine details, especially the ACCORD trial, a big problem that enrolled 100% of an ACCORD had diabetics. Other trials like HOT, H-O-T, looked at diastolic blood pressure. Many of these were observational, looking at systolic blood pressure after the fact. So I don't want to pick on their guideline process, but some of the trials were problematic. ACCORD found that large trial in diabetics found that if your diabetics get intensive glucose lowering, there was no additional benefit to getting a low blood pressure. The problem is that when you do a 2x2 factorial design, you have to be sure that the two factors don't interact. And in ACCORD, there was great interaction terms between hypertension and diabetes, really throwing into suspect the statement that lower blood pressure in the setting of intense blood pressure control doesn't add benefit. In fact, in SPRINT, there were no diabetics, but there were pre-diabetics, and pre-diabetics, the panel on the right, did obtain the same improvement in decreased cardiovascular events in pre-diabetics who received lower systolic targets. I think that ACP was looking at trials like this, published shortly after SPRINT, where they called it intermediate risk factors. This was a couple of thousand patients randomized with low pressures, 130 range, low ASCVD risk scores who got candesartan and diuretics, and they did not see a benefit at all, kind of supporting the idea that if you're healthy, you probably don't need to have a systolic pressure in the 120s. So I think I'm under the wire, a few seconds left. My summary is that the majority of global hypertension guidelines are similar to the 2017 ACC, that SPRINT demonstrated superiority of 120 over 140 in high-risk hypertensives. ASCVD risk score especially recommends or warrants lower systolic targets. There's elderly benefit, even in frail individuals, below 130, and hot off the press, mild cognitive impairment was less frequent when systolic pressure was maintained below 130. I want to thank you. I was driving them to school. My son took the picture on the left of the bus this morning, and I was happy to see that Hannah today is going to be talking about this publication about the sugary beverage tax right here in Philadelphia. So thank you again.
Thank you, Jesse. That was very exciting to hear that there will be some overlap in our talks, particularly because I think that it's important to really get a sense as to how big of an impact this is having on all of society, but particularly on racial subgroups of individuals. So I'm Jorde Cohen. As Cheryl already introduced, I'm an assistant professor at Penn. I do a lot of research, which is my disclaimer, related to the interaction between obesity and high blood pressure with regard to cardiovascular risk, as well as disparities in access to care among racial minorities. And so it's no surprise that there's a big differential burden of hypertension by race. And this gets at the data that Cheryl showed earlier from Philadelphia, very, very similar to what we see nationally. Looking at the National Health and Nutrition Examination Survey from 2015 to 2016, the age-adjusted prevalence of hypertension in non-Hispanic blacks was about 40%. That compares to 28% in non-Hispanic whites and Hispanics, and an even lower 25% among Asians. However, despite having a higher prevalence of hypertension, unfortunately non-Hispanic blacks have much poorer control. When you look at the age-adjusted prevalence of controlled hypertension in that same group of individuals from the National Health and Nutrition Examination Survey, we found that there was about 51% control in non-Hispanic whites with regard to their degree of hypertension among all hypertensive individuals. And there's 44.6% control among blacks, an even worse 37.4% control among Asians, and 35% control among Hispanics. Interestingly, control was a bit better among women overall than compared to men. And this results in a great deal of morbidity and mortality risk. Hypertension actually accounts for about 50% of the difference in mortality rates that we see between black individuals and non-Hispanic whites in the United States. On the right is an example of a graph looking at hospitalization rates due to hypertension in the mid-2000s. And as you can see, rates increased over time in non-Hispanic blacks compared to whites. And there was almost a 5-fold increased risk of hospitalization among blacks for hypertension compared to non-Hispanic whites. That compares to a 2.5-fold increased risk in Hispanics and really no significant difference among Asians. And as I described before, that's also associated with even further morbidity and mortality. And even though the prevalence is higher in terms of hypertension in blacks and the control is worse, they're aware of their hypertension. So our black patients have a very, very high percent of awareness. 85% of patients that were interviewed in the National Health and Nutrition Examination Survey in 2012 were aware of their hypertension, and 77% were treated for their hypertension. That's very similar to the rates that we see in non-Hispanic whites. Actually, surprisingly, the worst rates are among non-Hispanic Asians, but also among Hispanics with regards to awareness and treatment for their hypertension. But taking all of that into account, we still see much greater morbidity, particularly among non-Hispanic blacks with regard to their hypertension. They tend to be diagnosed at a younger age with hypertension, as we saw with the age rates, with these mortality rates and hospitalization rates happening at very, very young ages among non-Hispanic blacks in Philadelphia. They tend to have greater severity of their hypertension, where we end up seeing poorer control, but also higher rates of resistant hypertension among black patients. And overall, just having more target organ damage, which I'll get into the biology behind on the next slide. But we see almost a 2-fold higher risk of fatal strokes in blacks who have hypertension compared to non-Hispanic whites, and over 4-fold increased risk of end-stage kidney disease among non-Hispanic blacks compared to non-Hispanic whites. And so there are several biologic and environmental factors behind why we see these disparities. I think that unfortunately, if you ask a lot of colleagues and a lot of people who work with hypertensive patients, the first thing they'll hear is that it's due to non-adherence. And I really think that that's an unfortunate way to lean on in terms of the reason that we're not doing a good enough job in managing these patients, because there's so much more to it. Some of it may be barriers in access to adequate care, but I don't think that we can just shrug it off to non-adherence. non-adherence. There's a lot more that we need to be doing in order to adequately treat these patients, and it starts with understanding the biology behind what's happening. Obesity, both a biologic factor and an environmental risk factor for increased risk of hypertension and morbidity associated with hypertension, in particular non-Hispanic Blacks and Hispanic communities. Additionally, the genetic risk, and so I'll talk about APOL1 a bit just in case there's anyone in the room who's not familiar with this, because I think it's something that's gotten quite a lot of press in my world, so I'm biased since I am a nephrologist, but it's a gene that we became aware of in the last 8 years. And people who have one risk allele, so if they inherited one copy of the gene from one of their parents, they are protected against developing African sleeping sickness, particularly common insect-transmitted fatal disease in West Africa. Much like the sickle cell story, though, if people have 2 copies of this allele, so if they inherited the high-risk version of this both from their mother and from their father, they have a 7-fold increased risk of ending up on dialysis due to hypertension. They also have a 20 to 30-fold increased risk of other types of kidney disease, regardless of hypertension status. And they also have about 2-fold increased risk of cardiovascular disease related to hypertension. And so this is a very, very substantial genetic risk that's present in about, with the 2 risk alleles are present in about 14% of the African American population. Very important for us to be aware of this. And it's not something that we actually know how to treat at this point in time, but it's something that we're taking into a great deal of consideration when thinking about things like kidney transplant and live donors. Additional genetic and biologic risk factors to consider are salt sensitivity. So not only do our patients, particularly minority groups, have greater exposure to high sodium, low potassium diets that are low in fruits and vegetables, but they also happen to crave salt more, and it's to no fault of their own. It's because of this increased salt sensitivity. They tend to retain more fluid as a result of retaining more sodium based on the physiology of their kidneys, and end up having impaired natriuresis, meaning impaired ability to diurese or to urinate out extra fluid. On top of that, there's vascular dysfunction that comes along with several minority groups related to reduced nitric oxide availability. What this does is this alters the behavior of the blood vessels so that they're not able to necessarily relax appropriately. They become stiffer, putting people at greater risk of developing vascular disease and cardiovascular disease related to hypertension as well. With environmental factors, I mentioned obesity and high sodium diet, but also thinking about greater risk of physical inactivity, particularly in subgroups of patients that don't necessarily have safe areas to go outside and to play in as children, and this is occurring particularly with youth, and with the increased screen time occurring in current youthful generation. Additionally, poor access to health care, always an important problem that we're aware of, as well as neighborhood segregation. And so this is something I'll talk about in one of the upcoming slides, where this is actually both related to socioeconomic issues, but also independent of socioeconomics. One thing that's very important to consider, though, when thinking about research related to race and different disparities in control of blood pressure and also outcomes, is that measures of race and ethnicity are often based on social constructs and not based on genetics or these biologic variables that I just described. A lot of it's self-determined nomenclature that doesn't reflect the complex heterogeneous genetics across different subgroups. And so, for example, Hispanic Americans, we group them together as Hispanics, but there's often a lot of genetic diversity across different Hispanic groups that results in a large deal of difference in terms of their long-term cardiovascular risk. There's a great difference in hypertension prevalence rates, for instance, across different groups of Hispanic populations. Dominicans, for example, have almost a 30% prevalence of hypertension, compared to many South American groups that have less than a 20% prevalence of hypertension. So very important to keep this in mind, that while it's very appealing to group patients together based on a lot of the population-based statistics that we look at, it's not always appropriate to. I mentioned neighborhood segregation. So neighborhood segregation represents a multidimensional construct that reflects minority versus white differences in neighborhoods that goes beyond socioeconomic differences. And a really great example of this was from the Cardia study, where they published data following patients for over 25 years and took into account how segregated their baseline neighborhood was and if they changed neighborhoods over the course of those 25 years and how that impacted their blood pressure. And they found that people who were at baseline in a very segregated neighborhood, particularly neighborhoods with high rates of Hispanics and of non-Hispanic blacks, had a much, much higher risk of developing hypertension during their lifetime. And if they moved from a high segregation area to a low segregation area, then their risk of hypertension and their average blood pressure declined. So very important to be aware of this, and this was independent of socioeconomic factors and of education. So many of these people were very highly educated. Many of them weren't necessarily in lower socioeconomic classes, but it has something to do with their neighborhood exposures, their cultural exposures, and reflects the importance of desegregating some neighborhoods and perhaps allowing people to have better exposure to a more diverse nutritional exposures, things like that. Other things that we're doing better at least, is the guidelines. And Jesse had spoken about this a bit in terms of the 2017 AHA ACC hypertension guidelines that had many partnering organizations that did agree with what they were doing. Part of that because they ended up representing a greater group of patients in their guidelines. They did a much better job of describing differences in how we should be treating our non-Hispanic black patients, particularly compared to our non-Hispanic white patients. And I think that part of this was thankfully because there was representation of minorities among the groups of partnering organizations that helped define these guidelines. The Association of Black Cardiologists had representatives that reviewed and took part in writing the guidelines, as well as the National Medical Association, which is a historically very diverse group of physicians. And to repeat the slide that Jesse had shown, we saw that there was a great increase in the prevalence of hypertension with these guidelines going from 32% crude prevalence of hypertension nationwide to 46% prevalence. And in particular, we saw very, very substantial increases among all groups, but considerable increases among minority groups. Most notably now, in our non-Hispanic black men, 59% of them have a diagnosis of hypertension with the new guidelines. That's a huge number. More than half of our black men now have hypertension. This is something we really need to be thinking deeply about, given that we know that we're also doing a worse job of helping these people control their hypertension. And the SPRINT trial, which Jesse also had mentioned, is an example of this. This trial is a landmark trial. It showed that you only need to treat 61 people with a blood pressure of less than 120 systolic in order to avoid one major cardiovascular event. We don't see numbers needed to treat like that very often, and that's why this study gets so much press. But very important to think deeply about which patients were included in this trial. When we think about big observational trials, we've been doing a much better job of making them very representative of larger groups of patients, and a lot of them are focused primarily on minorities. I'm part of doing work in the Jackson Heart trial, for instance, which is all entirely non-Hispanic black patients in that study for people who have been followed for over 15 years. But this is a trial, so this is a really fancy randomized control trial where they have to bring patients back into the clinic for many, many repeated visits, follow people very closely, make titrations to their medications. And I think that unfortunately, as a result of some of the cherry picking they did to try to identify a really adherent group of patients to take part in this perfect study, it ended up really not reflecting our group of patients. It ended up not being fully generalizable to the people that we tend to see in our clinics. Compared to the 28% of the US population that has hypertension of non-Hispanic whites, 58% of SPRINT was non-Hispanic whites. Compared to 40% prevalence in non-Hispanic blacks, only 30% of SPRINT was non-Hispanic blacks. Again, 28% prevalence of Hispanics, only 10.5% of SPRINT was Hispanics. And then non-Hispanic Asians were very rarely recommended. There was another group of race that represented about 2% of patients in SPRINT, which probably combines a group of multiracial individuals and Asians. And so the study was actually underpowered to look at differences across race. But they did. So the authors went back and looked more deeply to see how well did we do across different racial groups. And what they were able to see was that we did a good job. Non-Hispanic Black patients were able to achieve the goal when they were randomized to a systolic blood pressure of less than 120, as were Hispanic patients. No surprise there. But the really interesting lesson that we learned from all of this, and it's very, very small print, is that the patients, I don't think this will work. Over here on the side, no, not working. So in the left panel, the non-Hispanic Black patients required an additional medication in order to achieve the less than 120 blood pressure goal. So that's something that we need to keep in mind, that probably a big part of the reason that our Black patients aren't reaching their blood pressure goals is the fact that we're not giving them enough medication. When patients did achieve the goal, though, they did have similar benefit across the non-Hispanic Blacks and non-Hispanic whites in SPRINT. And so lastly, what I'll touch on is how can we do better to manage hypertension in minority groups. And I think that the next speaker will touch on this much more than I can. But there are a few things unrelated to the diet that I wanted to touch on. Particularly adhering to evidence-based treatment targets in all of our patients, not just the patients that we may have certain mental biases towards treating with evidence-based targets. Very important to educate all of our patients, regardless of what we perceive their health literacy to be, on the best measures to manage their blood pressure. Particularly what I see a lot of is that we don't do a very good job of out-of-office blood pressure monitoring in our minority patients. And that's something that can really empower patients, that can help them take control of their own blood pressure. I have a lot of, especially young Black men that come into my clinic, and the second that I spend an extra 10 minutes just teaching them how to use a home blood pressure monitor, helping them think about what that can do for their awareness of their health and their future well-being, they get really into it. They love technology. They've got no problem having another device in their house. A lot of them are available now on Amazon for $20 for a well-validated Omron device. There are really good opportunities here to get patients more engaged in their care. We just need to take the time to do it. Very important to address any barriers to doing it, whether that be health literacy, whether that be device cost, whether it be any other factors. We've got ways to address these things. Other things to consider if adherence really is an issue is fixed dose combination tablets. They're often covered by Medicare. Sometimes they're covered by Medicaid. We find really, really huge improvements the second we put somebody who's on 3 antihypertensives onto a single medication. Even not assuming non-adherence, but just issues with access to their medications, and that can sometimes help. And of course, diet, which will be a major focus of the next speaker. Also important to consider race and multimorbidity-directed treatment. So we know based on ALLHAT that thiazide diuretics and calcium channel blockers are our best option in non-Hispanic Black patients because non-Hispanic Black patients had a higher risk of stroke as their first-line therapy on ACE inhibitors or ARBs. So very important to consider which class of medication we're using, but if patients have diabetes or other risk factors, we should be shifting towards the appropriate medications for that, like ACE inhibitors or ARBs. Also consider a lot of the biologic factors I described, particularly the sodium retention and salt sensitivity, another reason to really think about using diuretics in these patients. And so in summary, race and ethnic health disparities exist in hypertension unquestionably, and they drive a lot of preventable cardiovascular health inequities. Black patients have greater prevalence of hypertension, lower rates of adequate control, and higher rates of adverse outcomes due to their hypertension, whereas Asian and Hispanics actually have low hypertension awareness and treatment, so we should be doing better there as well. Our ability to research risk factors is, of course, influenced by limited accuracy in terms of people's actual race, so it's also another consideration to take into account. Important to base how we treat patients on their self-reported race, but just be aware that more precision information will probably be available in the next 10 to 20 years. And additionally, Black and Hispanic patients are more likely to be burdened by multimorbidity, so very important to consider multidisciplinary approaches and make sure to address barriers to care. And thank you, and we'll do questions after.
Thanks everyone for coming tonight, and thank you to the organizers for a great job of getting us all set up. I also want to thank my colleagues who've helped with conducting this research, Aviva Musicus and Alyssa Moran, and our very own, Philly's very own Christina Roberto at Penn. So we've heard a lot about the problem of hypertension in Philadelphia, who is experiencing it, lots of folks are, and now I'm going to spend a little bit of time thinking about what can we do with it? What can we do about it? What can public health do about it? Lots of people, do a lot of research on ways to help individuals make changes to their healthy lifestyles. That's great. We want to see lots of that. But my talk today is going to spend more time on the policies. So it's really hard, as many of us probably can think about in our own lives, to make changes to our diet and our physical activity, to see changes in our weight. That's really hard. So how can public health help? How can we make environments that make it a little bit easier for us to do the thing that we really want to do to be healthier? So in particular, I'm going to talk about how Philadelphia got to the point of passing a sodium warning labeling law and get us thinking about some other possible policy options that research suggests might be helpful. So since you've heard these other talks, you do know that a third of Philadelphians have high blood pressure. And that's a lot. I don't know if you saw in one of the earlier slides, it's over 450,000 people in Philly. A lot of people have high blood pressure, both here and nationally. But even if you don't have high blood pressure, chances are you're still eating too much sodium. A lot of us are eating too much sodium, and it's a lot too much, not just a little bit too much. The average amount of sodium that we consume is 50% higher than the recommended maximum. So it's a lot. And a lot of it comes from restaurants. A big chunk of it comes from restaurants. So we don't really have a way of knowing how much sodium is in our restaurant foods, and we usually don't realize how much sodium is in our restaurant foods. So studies that ask people to estimate how much sodium is in their food show that people way underestimate by 1,000 milligrams. That's about half of the daily recommended limit of 2,300 milligrams. So people are underestimating by half of the entire day's worth of sodium when they're thinking about these restaurant foods. So we think we can taste it. We think we know what's high in sodium, but we really don't. So where does our sodium come from? Most of it comes from restaurant foods and packaged foods. We hear a lot of people talk about cutting sodium in their diet by getting rid of the salt shaker. And that's great, but you can see here it only gets you so far. Only about 5% of our sodium comes from the salt shaker. And then we've got another 6% that comes from the salt that we add to our food while we're cooking. So if we want to lower sodium, the place to do it is restaurant and packaged foods. That's where most of our sodium is coming from, and that's where we want to target for those reductions. Understanding this, Philadelphia's City Council passed a law, and that is requiring chain restaurants to tell us when we are consuming way too much sodium in their foods. So the law requires chains with 15 locations nationally to put a warning label on their menus or menu boards that will tell us when any one item has more than an entire day's worth of sodium. A single item, entire day. 23 milligrams of sodium, items with 2,300 milligrams of sodium have to have a label. And not just any label, a scientifically designed label. So this is where my colleagues and I were interested in helping understand the label. We conducted some research on what type of label would help consumers in choosing lower sodium items. We did an online experiment, and we randomly exposed people to menus that had different types of warning labels next to high sodium items. And we asked them to tell us hypothetically what would they order? Take a look at the menu. What would you like to order? They also told us what, how salty the food was, what they thought about how delicious the food was, and other attitudes about the food, how tasty they thought the food was, and they rated how much they thought the food would impact different aspects of their health, like blood pressure. We then took those research findings to council members to help us guide what the actual label looked like that was in the law. So we actually did a series of 3 studies that you can see here which labels we tested in those studies. The first 2 focused on text and the phrasing of the text. And then the last study, which was the largest study, compared all of the labels that you see here, all the different designs. Which symbol is best to help with, do we need text or not? We also tested black and white versions of all of the ones here in study 3 to see if color mattered. And you'll notice the top one on study 3, the little triangle there with the salt shaker in the middle, that is the label that is in New York City's law. So New York City has a similar law. It's the only other place in the country to have a sodium warning label law, and that's the label that they use. So there was a lot of pressure to use the same label, but we wanted to see which label really helps folks best understand what we're trying to get across and helps people choose lower sodium items. And we wanted to make sure that the label that was in the law was one that science said was best equipped to help us understand and change what we're ordering. So from our first 2 studies, we found that using the word warning was helpful. You remember it was comparing sodium warning to high sodium. So we said using warning seemed to be helpful there, and that sodium fared a little bit better compared to salt. So we were worried about people misunderstanding salt with all the boutique fancy salts, and maybe they think it means flavorful and Mediterranean salts and pink salts and all those things. So we verified the wording around sodium warning, and then our third study included the sampling of participants that better captured Philadelphia's demographics. So we wanted to try to make it look a little bit more like Philly, and this is the one where we tested all the different design styles. So here are pictures of the sample menus that you might have seen if you were taking part in our online study. And on the left side is a text-only label there under the chicken baskets. You can see those have the sodium warning text label. And then you can see the reference statement down at the bottom telling people, oh yeah, you shouldn't have more than 2,300 in a day. And then on the right side, you can see the traffic light labels. So, only telling people when an item is over the entire day's worth of sodium leaves a lot of room for folks to still choose very high sodium items, even if they don't have the label. So the thinking here was, can a traffic light label help with understanding different levels of how much sodium they were consuming? This is a really big challenge to implement, but from a research perspective, there's a lot of research supporting traffic lights, so we wanted to see how it fared. What did we find? We found, in general, that sodium warning labels helped people order less sodium. Great. It works, hypothetically. It's an online experiment. Depending on the specific label that we used, that folks saw, there was 1 to 12% less sodium that they ordered when we said, which item would you like? On average, those items contained 1 to 12% less sodium. This was about 20 milligrams to 150 milligrams. Or it's a little less than a small bag of Lay's potato chips. That has about 170 milligrams of sodium. So it can make a difference, the type of label that you use, and people noticed it mostly. About 60% of the people noticed the label at the end of the study. They rated things as being saltier. The best performing labels were our traffic light label and the sodium warning with a stop sign there. So those tended to have higher amounts of sodium reduction across the different measures that we looked at, and some better attitudes and ratings outcomes that we saw there. And we also saw, big picture, that we needed text to let people know what this label meant. They didn't really understand the New York one. It was there on its own. They didn't notice it as much. They needed that extra text to know what it meant. So this was something that was really important for us to understand about an effective label, that we needed that text there. So this is the actual final label that Council passed last year. And you'll notice it's a bit of a compromise, as legislation often is. So we have the New York City symbol, but importantly, we've got that text next to it. And it could be in color or in black and white. That didn't matter too much. So this was the actual version that ended up getting passed. Now, we do want to keep in mind several limitations of this study, right? It's an online hypothetical order. We didn't get to look at what people actually were eating or what they actually ordered, but we were happy that we had some scientific guidance on what would be a better design, and to help us evaluate which parts of a label we could change. Not just sitting around a table saying, I like this one, or I think this one's better. We actually were able to help us help understand what was more effective. It was a one-time exposure. If we see these labels multiple times on multiple menus, that's going to have a little bit of a different impact than if we just see it once in an online, sample menu. So it was a short exposure. And we did see some small changes in sodium that we think are relevant on a population level, for especially somewhere like Philly, where we have such a big problem with high blood pressure. But our study didn't have quite enough power to pick up some of those smaller changes that we think do actually matter. So we have 3 ways that we think this label can help lower the amount of sodium in folks' diets. First, obviously, educating consumers so that they can make a healthier choice. Second, if you're seeing these warning labels, you're seeing press articles about the law, you're going into restaurants with friends and family and noticing it on the menu and having conversations about it and thinking about it in other scenarios or other cities when you're eating, that's going to help improve awareness and kind of think about where there might be other parts in your diet or in restaurants that we can kind of cut back on sodium. And third, which is the piece that I'm most excited about and where I would expect might have a greater population level impact, is that it could spur restaurants to reformulate their foods so they don't have to put the label on the food. And this actually would be a big win because it doesn't rely on someone to notice the label, to know what it means, or to when they're really hungry and wanting something really tasty, have to make a really hard decision not to get the item that they want. It just happens because they don't even know, and the item was reformulated to have a lower level of sodium because the restaurant didn't want to have to deal with labels. So that's something that would be really exciting. It's really hard to measure. So we're not going to have a good sense of if that's happening, especially if it's only Philadelphia and New York where it's required, and these chains usually have locations all across the country. Are they going to change their menu items just for us? We are pretty important, so we hope so. But this type of population level impact is something that we like to see in public health because it doesn't rely on an individual to have to make a really hard choice. So how can we, nudge folks to do something, make the healthy choice easier without even knowing it? So that's something that we're excited about. So we have this exciting new public health law. You'll start seeing these labels come September. And we had the help of science to design a nice label and 3 ways that it might impact our diet. But really overall, we might expect the effect of this policy to be modest. We're not expecting this is going to cure hypertension in Philadelphia. We eat a lot of sodium, and really not very many of the items meet the threshold for having this label. And when they do, we're not eating those particular items all the time. So overall, we're expecting this to have a modest effect, but still something that we think is worth doing and could matter at the population level, especially for Philly, with all the numbers that you saw before about the problem that we have here. So it's important that we think beyond sodium warning labeling and what else can we do. So I'll talk more about FDA targets next, but there are a number of promising policy approaches that research suggests may help us with preventing and treating and controlling high blood pressure. We can utilize policies like nutrition standards, and this dictates what foods that governments or businesses like hospitals or big employee cafeterias, which foods that they're able to purchase. And we have this type of policy here in Philadelphia, and it has a requirement for all of the food that the city purchases to meet certain standards. We have standards on the sodium limits. We also have other requirements around fiber and fruits and vegetables and whole grains, other nutrition benefits that we want to see. But health institutions, they could decide to have their own nutrition standards and say, the food at my hospital is going to meet this target. And that's what our Good Food, Healthy Hospitals initiative is doing, is helping hospitals with meeting voluntary guidelines around foods that are being served. So we also want to see policies that encourage healthy lifestyles. So things like making physical activity easier is going to be a great thing for high blood pressure. Any policies where we can gently nudge and make the healthier choice the easier choice with our lifestyles is going to help with high blood pressure. Something particularly important in Philly and other urban areas are policies that impact air quality. So we know that air quality has an impact on our cardiovascular outcomes, particulate matter like PM 2.5. It doesn't just matter for the environment, it matters for health too. So we need to be conscious about air quality policies. Lots of policies can impact high blood pressure indirectly through weight loss. So policies that make weight loss easier are also going to help high blood pressure. For example, if there's a policy about which health providers are reimbursed by insurance to provide weight loss counseling, and we can make a change to that policy that would allow more people to access nutrition counseling and weight loss counseling, that would mean more people could get those services and more people could lose weight, and a big benefit to blood pressure. One of the best things we can do to prevent and control blood pressure, high blood pressure, is to lose weight. So policies that impact weight are also a win. Of course, smoke-free policies there's a big role there. The negative impact of smoking on blood pressure is just one of the very harmful effects that smoking has, and so what we can do around smoke-free policies is going to be really helpful for moving the needle on high blood pressure as well. So what about those FDA targets? Well, they are voluntary right now, and there's a good case to make for them being mandatory, but one of the benefits to them being voluntary now is that they're flexible, so they can be changed easier than if they were required, and that can help with this kind of early stage, formative stage around setting these sodium limits in place, voluntary guidelines. So they also are intended to reduce sodium gradually over time. And research shows that if we do it gradually, we don't quite notice. We can reduce sodium 10 to 15% and we don't taste it, we don't notice. So gradually over time, if we can lower our sodium and shift the preferences of our population to prefer lower sodium tastes, that's a way to do it that doesn't totally scream at your taste buds all at once. So we don't tend to notice those smaller taste reductions, and over 2 to 10 years, these targets these sodium targets for food companies would get us closer to meeting our sodium targets in our diet. They had a lot of factors that they had to consider around setting these targets. Food safety and preservation matters. So thinking about the texture of the food, the stability, those preservatives in the food is something that food companies would say they need time to kind of play with in a way that doesn't scare off consumers. And the targets are set both for having, average targets as well as those upper limits. So after 10 years, if food companies voluntarily all meet these recommended sodium targets for these high common food categories, then FDA's estimation is that after 2 years, it would lower the amount of sodium that, on average, that Americans are consuming. So right now, we're consuming 3,400 milligrams a day on average. Remember, the limit is 2,300. So after 2 years, if all the companies met these limits, it would get us to 3,000. And then after 10 years, we still meet these targets. That gets us to a recommended level, to 2,300 in our average diet. So 10 years is a long time to wait, so we need some of these other policy tools that research suggests can help us in the meantime. But certainly the FDA voluntary targets are going to be exciting, and maybe we'll see at some point that they transition to being more than voluntary. And that's all I have. So thank you for your attention and time.
So now I'd like to invite all our speakers to come up and have a seat. And if folks have questions, we have a mic set up just in the center there. And if you ask your question through the mic, we can all hear you. So thank you. And I'm going to use my moderator's prerogative to ask a first question. This one I think is for Jorde, but other folks chime in. So in my career as a family doctor, seeing lots of patients with hypertension, my experience is with young black men. Often my first visit with them is with a diagnosis of I was hospitalized for an MI.
Yeah.
So I was surprised by the awareness numbers you showed, and I wonder if you could talk about whether that is is that across all groups, or,
I think that data is skewed because it's from the National Health and Nutrition Examination Survey. It's a little bit older data, so I think that things have changed a bit demographically in the last few years. We have a lot more obesity, causing a lot more younger hypertension too. But I think it tends to be well representative of patients, but I do think that it's of people with an actual diagnosis of hypertension who are aware of it. So I think there are a lot of people who aren't even aware of their who aren't aware that they're not aware. There are a lot of people, for instance, who will come in with an elevated blood pressure one time and then think, oh, I'm fine, come back and have a normal blood pressure on other visits, when in fact they have something called masked hypertension, where they just have elevated blood pressure outside of the clinic most of the time, and the majority of the time in the clinic they have a normal blood pressure with the occasional elevated reading. And that, I think, is definitely not captured, and those, I think, are the young black men that we're seeing coming in with MIs. Those are people that you can only capture their high blood pressure by screening their blood pressure out of the office. So this is something, the USPSTF made this recommendation in 2015 that we should be screening everybody outside of the office, essentially, and that really hasn't been implemented, and we need to do a better job of that. Some of the local grocery stores are doing a better job of having kiosks that are somewhat validated to check a blood pressure, which I think is incredibly helpful. But I think that we should really just be educating all of our patients, regardless of their blood pressure status at this point, that they should get a home monitor, that everyone in their family should check their blood pressure every few months just to make sure that they're within a reasonable range.
Great, thank you.
Hi, Tom Farley from the Health Department. So it's exciting to see the medical approach and the public health approach talked about in the same conference, same session. Usually they're in separate worlds, and I think that's a lot of the problem. And so this is a question kind of from a frustrated public health guy. The medical approach is we screen a lot of people and we find that nearly half of them have hypertension, and among African Americans it's more than half, and everybody's going to be on medicine. Public health people say, gosh, that doesn't seem like an appropriate way to deal with this problem. This is clearly a population level problem, and so we ought to be trying to do things like get the food industry to put less sodium in there, Because our problem is that we are all suffering from chronic sodium intoxication, and that, there's a way to change that. But I don't, when we've tried to work against the food industry to lower their sodium levels, we get tremendous resistance, and we don't feel a large constituency behind us of people saying, yeah, you're right, we need to really change that food that's really dangerous that's being served us all the time. So the question is, how do we get the half of Americans that have hypertension and the doctors that treat them, which is going to be a lot, to be part of that constituency for public health, to really argue for these sodium level policy changes so that we're not always sticking with this medical approach, which is, it's complicated and difficult. That's either for you, Dr. Cohen, or Dr. Goldman. I know it's a tough question, but.
Yeah, unfortunately, I agree with you. So I do completely agree that hypertension is a public health problem, that the majority of patients don't present like Dr. Bedegol's. The majority of hypertensives are not going to have a trigger that makes them pay much more attention. And I think it's really quite daunting. I don't mean to be pessimistic, but I feel that healthcare providers are completely outgunned by the food industry. We don't have celebrities. We don't have billboards, colorful and commercials assaulting us throughout the day. So I think it would require to change behavior, as was talked about, which is enormously difficult. And I think it would require essentially a national initiative at the country level to change, to bring about the type of initiative you're talking about. So we can sort of chip at it by adjusting sodium and encouraging weight loss, and exercise and high potassium diets and all the things that Jorde mentioned. But changing behavior, the physicians, we don't, I hate to use the cliche, but we don't have the time to spend a lot of education, that it would have to be a team approach, and the physician, I think as was mentioned, we can point at the other members of the team to educate, but I don't see physicians taking on the task.
And so I have an added point to that. There was a very, very cool study that came out last year, the Barbershop Study. It was a New England Journal of Medicine study where they randomized different barbershops out in California to educating patients on their high blood pressure and screening for high blood pressure versus not doing anything. And there was a huge benefit to getting into the communities and educating people from the sources that they trust. I think that it will take enormous amounts of policy change to actually make a huge change, but adding to the places that we can chip away at least as a city, are getting into churches and getting into barbershops, educating people from the places where they trust the individuals that they're hearing from and where the people look more like them, as opposed to potentially somebody that they feel like is talking at them as opposed to with them.
Yeah.
And just to follow up with that, this barbershop model has been looked at repeatedly.
Yeah.
And as soon as the investigators go away, the effect extinguishes.
Yeah.
So it's nice to get a publication and collect the grant money, but when the grant money goes away, then the blood pressure effect goes away. So I do think it's education and a team approach with national initiatives.
Yes, thanks. So just a comment before I said, and that is that education might help people recognize, have high blood pressure, and get treated. Doesn't change what the food companies are doing and how much sodium they're dumping into the food. So we need to figure out how to build a constituency to really pressure the FDA to put in mandates so that they really aren't putting us in.
We have to get patients to boycott.
Thanks.
Hi, my name's Jim Bueller. I'm in the School of Public Health at Drexel, and I'm impressed by the level of apparent complexity in the new guidelines. It's not as straightforward as the headline would suggest. Obviously, as you've indicated, there's nuances and variations in how they would be implemented for different groups of patients. I'd be curious to hear what you're seeing among the primary care community. I mean, you two are the top experts, among the top experts here and specialize in this, but for the primary care providers that are on the front lines, are they embracing the new guidelines? Are they confounded by the new guidelines? Are they trying to implement them? Are they doing it right? What's your sense of how this is, the new guidelines are working in practice, outside of the big academic centers and clinics like yours?
Yeah. So I think I think you correctly said that it's a complex. It's not only difficult to change behavior among patients, but it's more difficult to change behavior among physicians. You know, what's especially problematic, you probably know, is that JNC8 made an attempt to create before these 2017 guidelines. I think it was 2013 or 14 for JNC8. And they attempted to create a purely evidence-based set of guidelines that led to, you may remember, a pullback of higher blood pressure targets. And then they were, unfortunately, they came out with, and Sprint came out really shortly after the JNC8 guidelines that said the exact opposite, that lower targets. So that certainly created tremendous confusion among physicians, that first you say move it up and then you say move it down, so I'm going to do nothing. So I do think, though, it's change is incremental. I do believe that the American Heart, being an enormous organization, has been sort of slowly tightening the screws and with outreach to physicians. I think there's still a lot of therapeutic inertia to try to get below the 140 level. I think Jorde and I and our hypertension people who demonstrate hypertension interest are targeting lower, but I think we're again really quite, I would go so far as to say, in my opinion, the majority of physicians outside of large healthcare institutions are not targeting to the 120 or 130 level yet.
I agree. Yeah, I've been doing a lot of work with the American Medical Association on this, and so I've been going out to the communities and speaking, discussing the guidelines and the caveats, but also the benefits of adhering to aspects of them with community physicians, and hearing a lot of pushback, which is understandable, because I think that the perspective is this doesn't really look like my patients. These guidelines are based on these big trials that were perfectly done that don't necessarily look like the situation I see in front of me, and I have 10 minutes to see this person and do all of these things, and really that aspect of it and explaining how things have shifted and this ping pong effect of rotating guideline numbers has really been quite challenging for them to really adhere to, because patients have lost some trust in it since things changed so rapidly. I think that we can do better. I think that part of what the message that we're trying most to get across to physicians is just measure blood pressure better, because we're probably doing worse than we realize, actually, or maybe we're doing better. But a lot of the blood pressures that we're obtaining in the clinic just aren't done right, and so just start with measuring better. And then as you start measuring better, getting people to measure their blood pressure at home better, the better blood pressure control can come after. So that's sort of a big push that we're working on, is trying to just get a real number, because what are you treating? What's it worth as a number if you're not actually checking a good one?
Yeah, Jorde said it perfectly, but I would reinforce it that, I think if you would, it's a rarity to see blood pressure checked perfectly in the office. And we could all easily name the 10 things we do wrong in checking pressure. So we've been doing it the same way for 100 years, and it's shocking how poorly we check blood pressure in the office.
So that blood pressure that's at 140/90 might actually be 130/80 if you recheck it correctly, too.
And to add the public health perspective on this, too, at some point we've got to figure out how to turn off the tap, right? The problem of obesity is increasing, blood pressure problem is going to be going up. Our diets are not really, getting much better, except now in Philly after the sugary beverage tax. So, at some point we've got to turn off the tap, or we're just going to be flooding, primary care and physicians in ways with lots of patients that we're having a hard time treating.
So,
Thank you.
can I just add that there is a large-scale project working with hospital-based practices and federally qualified health centers on blood pressure control. There's a learning collaborative using EMR data and dashboards and a whole bunch of other strategies to try to drive improvement. I will say from that, we know that baseline blood pressure control, even to 140/90, is around 60%-ish, low 60s. So even there, we have a lot of work to do. But people are coming together to try to solve these problems.
How you doing? Asking a question more on the public health side. I'm not a doctor, but my understanding is generally diet is paramount. Do you ever ask these groups of people that you talk to, do they know how to cook? Do they think that they're good at cooking? Because if we can get them out of the restaurants and cooking on their own, I feel like it's less a boycott the restaurant and more just go cook food for yourself. And in my experience, I can eat like broccoli covered in butter and salt, but that's still better than a Big Mac and fries. So I'm like, is there any effort to increase the amount that people know how to cook? And I know there's like food deserts and like people live in neighborhoods where they don't have access to good stuff. Do you ever ask your patients, do you know how to cook? Do you like your own cooking? Work on that. That's all I gotta say.
Yeah, I mean, I think the short answer is yes, that a lot of behavioral treatments for obesity or for controlling hypertension throw everything they can at the problem. It's a very complex problem. Cooking is absolutely a part of it. And the part of the challenge is that changing behavior is hard. And so no kind of one-size-fits-all approach will work, and folks are going to need to do lots of different things. At the end of the day, even if you get folks to like cooking more, they're still going to walk down the block and be bombarded with 15 delicious smelling, tasting, sounding cheap things that put someone in the place of having to make this very, very hard behavioral, change. So I agree with you. Let's teach people cooking. Let's get them comfortable with cooking more at home. But we need to do lots of other things as well.
I'll go for the easy joke and say you don't want to eat my cooking.
So I think we have time for one more question, and then we'll have time at the reception for informal questions with the speakers.
You discussed how changing the definitions has increased the number of people who carry the diagnosis. My question is, have we seen an actual increase in blood pressures, apart from the definitions, but just the raw blood pressures over time, so with people gaining weight, people being more sedentary, people not eating out at restaurants more? Is there data about that average blood pressures have gone up over the years, or have blood pressures just been the same, but we haven't been treating it?
We've seen it parallels the rates of obesity very clearly. We also see younger age of diagnosis of hypertension now than we did several years ago. So with each progressive rise in the national BMI, there's earlier age of diagnosis of hypertension because more obese people are more likely to, it's accelerated aging essentially when you're obese. And so it stiffens your blood vessels. It makes people more likely to develop hypertension at younger ages.
Thank you.
I would just make the comment that, nationally, blood pressure, right, there was this immediate reclassification, but if you follow the same blood pressure categories, United States is starting to plateau with the exception of these minority and young people. So the U.S. is doing better. What's fascinating, and maybe not directly relevant here, is that globally in third world countries, rates of blood pressure are blasting off like a rocket. So United States and first world countries, it really is plateauing.
Because of treatment? Because of better treatment? Or
Yeah,
more aggressive treatment?
right, so there is, as Jorde mentioned, it's not for lack of access to care in the United States. People, we used to say, oh, people don't know that they shouldn't eat salt. They know. People know that they shouldn't be obese. They know.
Right.
So the United States, it's plateauing with the exception of the minority populations. Globally, I think the rates have gone up by 90% in the last 20 years of blood pressure. So shocking.
Interesting.
Okay.
Thank you.
Thank you.